In 2007, we started the first precision medicine study across tumor types, Initiative for Molecular Profiling in Advanced Cancer Therapy, or IMPACT. We hypothesized that tumor molecular profiling will optimize selection of anti-cancer therapy, leading to improved outcomes compared to the standard approach. Patients with various tumor types who exhausted standard treatment options or with rare cancers are referred to our Phase 1 program for investigational therapy. CLIA-certified tissue molecular testing was ordered. The number of genes analyzed ranged from 1 to 50, depending on the time of testing, and including genes in the PI3 kinase, AKT-mTOR pathway, MAP kinase, receptor tyrosine kinase, and other pathways. Patients with tumor alterations were treated with match-targeted therapy when possible. If match therapy was unavailable, they received non-match therapy. Patients were treated on clinical trials with investigational agents against various targets or on trials with FDA-approved drugs for other indications as single agents or in combinations. Consecutive patients who had tumor molecular profiling were included in this analysis, which was retrospective and exploratory. From 2007 to 2013, tumor molecular testing was ordered in 3,743 patients. 1,307 patients, or 35%, had at least one molecular alteration. Of these patients, 711 received match-targeted therapy and 596 non-match therapy. The median age was 57 years. 39% were men. Patients were heavily pretreated. The median number of prior therapies was 4, ranging from 0 to 16. The most common tumor types were gastrointestinal, including colorectal cancer, gynecologic, breast, melanoma, and lung cancer. The overall objective response rate was 16.2% in the matched group versus 5.4% in the non-matched group. Additionally, 18.7% of patients had disease stabilization for at least 6 months in the matched group compared to 14.7% in the non-matched group. The respective disease control rates were 34.9% and 20.1%. The p-value was below 0.01. The median progression-free survival was 4 months in the matched group compared to 2.8 months in the non-matched group. The p-value was below 0.01, and the hazard ratio was 0.67. The median overall survival was 9.3 months in the matched therapy group compared to 7.3 months in the non-matched therapy group. The p-value was below 0.001, and the hazard ratio was 0.72. The 3-year overall survival was 15% in the matched-targeted group compared to 7% in the non-matched group. The 10-year overall survival rate was 6% and 1%, respectively. We performed univariate and multivariate analysis to determine the association between survival and patients' baseline characteristics. Independent factors predicting shorter overall survival were molecular alterations in the PI3 kinase, AKT-mTOR pathway, liver metastasis, elevated LDH levels, performance status greater than 1, decreased albumin levels, elevated platelet counts, and age 60 years or older. Then we used these independent factors to develop a prognostic score. Each factor equals 1 point. The median survival of patients with 0 points was 13.7 months, 1 point 11 months, 2 points 7.4 months, 3 to 4 points 4.6 months, and 5 to 7 points 1.9 months. When we added the type of therapy in the multivariate analysis, non-matched therapy was associated with shorter overall survival in addition to the previously described baseline characteristics. Therefore, match-targeted therapy was an independent factor associated with longer overall survival. In conclusion, our data demonstrate that match-targeted therapy was associated with long-term survival. The 3-year overall survival rate was 15% in the match-targeted group compared to 7% in the non-matched group. The 10-year overall survival rate was 6% and 1% versus 1%, respectively. In multivariate analysis, match-targeted therapy was an independent factor predicting longer overall survival. PI3 kinase, AKT, mTOR pathway abnormalities were associated with inferior outcomes compared to other alterations. We developed a prognostic score for overall survival, including molecular pathway abnormalities. Ongoing clinical trials, including our randomized IMPACT-2 trial and, more importantly, ASCO STAPLE, will help implement precision medicine in oncology. Since we started the IMPACT study in 2007, the term precision or personalized medicine has evolved. Precision medicine currently refers to the use of targeted therapy that inhibits specific biologic abnormalities that are thought to cause carcinogenesis, or to the use of cancer immunotherapies to generate an immune response against cancer. Implementation of precision medicine requires complete understanding of tumor biology, including a patient's immune characteristics that drive carcinogenesis, discovery of effective drugs and development of therapeutic strategies that inhibit carcinogenesis, and the definition of precision medicine should be rigorous. Finally, patients with cancer should have access to next-generation sequencing and immune marker testing, as well as to effective drugs at the time of diagnosis and during the course of their disease to optimize treatment selection. In closing, I am optimistic that in the next few years, we will dramatically improve the outcomes of patients with cancer with increasing implementation of precision medicine. Thank you.
Okay, thank you very much, Leah. Lots of data in that abstract. So I'm going to ask Dr. Diefenbach to provide some additional context and perspective.
This is the first and largest study that shows that matching treatments to genetic mutations in tumors in patients with advanced cancer improves survival. Patients with advanced cancer who underwent molecular profiling and were found to have actionable mutations and treated on the basis of those actionable mutations had significantly improved overall survival compared to patients who were treated with conventional chemotherapy. Most of these patients received drugs that were either FDA approved or were in advanced clinical trials, so people did not have to go out and reinvent the wheel to treat these patients in a completely new way. Prior to precision medicine, patients were treated on the basis of what kind of cancer they had. Breast cancer. All breast cancers were treated like breast cancers. Chemotherapy treated patients on the basis of kinetics of growth, how rapidly the cells grew. But a breast cancer patient, as we've heard, can have a cell that's much more like a lung cancer patient genetically than another breast cancer. This patient could have multisatellite instability and have a cancer that's much more like a GI cancer. But to treat cancer based on neighborhood ignores all of these genetic differences. Precision medicine allows us to really focus on what the genetic aberrations are in the tumor itself, not on the neighborhood on the tumor, and not on the growth kinetics of the tumor. As such, this therapy is this method of molecular profiling tumors and treating on the basis of actionable mutations is the wave of the future. And large-scale efforts such as ASCO's TAPLE or the NCI's MATCH trial will bring these efforts to many, many more patients and hopefully usher in a new way of treating advanced cancer patients that will improve overall survival for many more patients.
Great. Thank you very much, Dr. Diefenbach. You know, this is another study that there's this continuous drumbeat about if you can find a target, match a drug to the target, treat the patient with that drug, that perhaps you can get somewhat better outcomes for those patients. It's highly context dependent. You know, we know that precision medicine is effective in treating patients where there's a bona fide target and an effective drug. You know, the drugs that treat EGFR mutations, the drugs that treat BRAF mutations, you know, and so on and so forth. It's complicated in these advanced cancer patients with NGS testing, where you don't know what you're looking for. You don't know what you're going to find when you find it. You don't know what you're going to do when you get the results of the test. But most importantly, you know, I think this kind of precision medicine practice still needs to be done in the context of information gathering and learning and research. And that's where I think the IMPACT study is such a good example. There's a lot of this that's going on in routine clinical practice these days. I think that's probably a leap a little bit too far ahead of, you know, what the data would support, at least in patients with far advanced cancer. But doing this in the context of a research program is a completely valid and, in fact, important thing to do, so we can get the information we need about under what circumstances these approaches actually work.